development of mental disorders and their effects on behaviors and relationships. And many of the psychodynamic models that we have seen in mental health and sometimes still use today, they've all begun with Sigmund Freud. And these theories are important in the development of our therapeutic relationships with our patients. They're important for techniques and interventions as well. And in the next few slides, we're going to go over some of the different psychodynamic theories. All right, so let's begin by talking about Sigmund Freud and his psychoanalytic theory. And Freud was the founder of psychoanalysis, which is a method for treating mental illness. And it's also a theory that explains human behavior. So Freud believed that the human mind is structured into two main parts. So there's the conscious and there's the unconscious. And then he also believed that there's this little part in between the conscious and unconscious called the preconscious. So the conscious, we're just going to kind of review this from probably your psychology classes, but the conscious mind contains all of the thoughts, memories, feelings, and wishes of which we are aware at any given moment. And this is the aspect of our mental processing that we can think and talk about rationally. Now, the unconscious mind, it's like a reservoir or a storage area of feelings, thoughts, urges, and memories that are outside of our conscious awareness. And the unconscious contains content that may be unacceptable or may be unpleasant, such as feelings of pain, feelings of anxiety, or conflict. And there are some memories in the unconscious that may not have been unpleasant or unacceptable. So we can still retrieve some of them from the unconscious and bring them to the conscious if they haven't been horribly unpleasant or horribly unacceptable. And that's where the preconscious comes in. So the preconscious can grab things from the unconscious and move them to the conscious. So those painful, unpleasant, or unacceptable memories, feelings, or experiences typically are locked in our unconscious, and they're really hard to bring out to the conscious mind. But Freud did believe that while the unconscious mind is largely inaccessible, the content can sometimes come up unexpectedly. So he believes sometimes we might have dreams that would bring the unconscious memories to our awareness. So according to Freud, thoughts and emotions outside of our awareness still influence our behaviors, even though we are unaware of these underlying influences. The unconscious can include repressed feelings, maybe hidden memories, habits, thoughts, desires, and reactions. And memories and emotions that are too painful, embarrassing, maybe they're shameful, maybe they're distressing to consciously face for us. And so that's why we've stored them in the unconscious mind. So Freud used techniques such as the dream analysis, and he also used a technique called free association. And free association means just sharing random thoughts to bring these feelings to light. So he thought that if he was able to bring some of these unpleasant feelings from the unconscious to the conscious and that we were able to talk about them, maybe they would change some of our behaviors or distressing feelings about those memories. So, personality development. Freud's personality structure consisted of 3 parts, and you've probably heard of these 3 parts, but the id, the ego, and the superego. So we're going to talk about those 2. So the id is present at birth, and it is formed by the unconscious, and it works to satisfy basic urges, needs, and desires. And these can also include sexual and aggressive tendencies that arise from the body. The id operates based on the pleasure principle, which is the idea that needs should be met immediately. And if these needs aren't satisfied immediately, then tension will arise. So for an example, infants. When infants are hungry, they cry. And if the parent doesn't give them a bottle right away, they cry louder and louder and louder until their needs are met. They get that bottle and they're full. Another example may be that Sally was thirsty, and rather than waiting for the server to refill her water, she reached across the table and drank from Mr. Smith's water glass. So those are all kind of examples of id. The ego deals with reality and tries to meet the desires of the id in a way that is socially acceptable in the world. So this means maybe delaying gratification and helping get rid of the tension that the id feels if the desire is not met immediately. So the ego recognizes other people have needs and wants too, and being selfish is not good for the long run. So an example, going back to Sally, Sally was thirsty. However, she knew that the server would be back soon to refill her water glass. So she waited until then to get a drink, even though she really wanted a drink from Mr. Smith's glass. The superego is based on morals and judgments about right and wrong. So even though the superego and the ego may reach the same decision about something, the superego's reasons for that decision is based on morals and values, while the ego's decision is based on what others may think or what's the consequence of my actions. So an example of the superego is Sarah knew she could steal supplies from work and no one would know about it. However, she knew that stealing was wrong, so she decided not to take anything, though she knew she probably wouldn't get caught. Sexuality. So energy or psychic drive associated with the sexual instinct or libido resides in the id. So Freud believed that personality development in childhood takes place in 5 stages: the oral, anal, phallic, latency, and genital stages, and you don't need to know those stages. But during each stage, sexual energy or libido is expressed in different ways and through different parts of the body. So Freud believed that if the child experienced frustration in any of these stages, they would experience anxiety that would persist into adulthood. And then there's psychoanalysis, and psychoanalysis is a therapeutic process of assessing the unconscious conflicts that originate in childhood, and then these issues would be resolved later on when the individual has a mature adult mind. So again, bringing memories from the unconscious mind to the conscious mind to relieve an individual's psychological distress. And then anxiety and defense mechanisms. Freud believed that anxiety is a reaction to danger, and defense mechanisms are used to protect ourselves from feelings of unwanted anxiety. And we'll talk about these defense mechanisms later on in chapter 9. And then transference and countertransference, we'll talk about these a little bit later too, but just to give you an idea now, transference is the displacement of thoughts, feelings, behaviors originally felt in childhood onto a person in a current therapeutic relationship. So like a patient to a nurse or a patient to a therapist. So just to give you an example, a woman's feelings toward her parents as a child may be directed towards her therapist. And psychoanalysis uses transference as a tool to help the patient understand where their emotional problems come from or why they have emotional problems. And then countertransference is opposite. So the therapist or the caretaker displaces their feelings and attitudes onto the patient. And countertransference becomes a problem when these feelings and perceptions are based on other interpersonal experiences. So an example of countertransference would be that a patient reminds a nurse of a beloved grandmother. And instead of therapeutically interacting with the patient from an objective perspective, the nurse feels an unexplained attachment to her and treats the patient as if she were the nurse's grandmother. And the nurse may miss important assessments and intervention data. All right, so interpersonal theories stress the importance of human relationships and instincts, and drives are less important. So Harry Stack Sullivan believed social experiences shaped personality. He also viewed interpersonal relations as the basis for human development and behavior. And he believed the health or sickness of one's personality is determined by how they deal or behave with others. So, for example, a man is passive aggressive to everyone who contradicts him, and the maladaptive behavior began when he was unable to express his disagreement with his parents. Humanistic theories are based on the belief that all human beings have the potential for goodness. And Carl Rogers was a psychologist who introduced client-centered therapy. And he believed that in order for an individual to grow or learn about and accept themselves, they need an environment that provides empathy, unconditional positive regard, and genuineness. So empathy is putting yourself into your patient's shoes, kind of feeling what they're feeling, understanding their feelings. And unconditional positive regard is being non-judgmental. And then Abraham Maslow's hierarchy of needs is used to prioritize care. And basic needs such as food and shelter should usually be met before the higher level of needs can be met. However, in mental health, it's not always that simple. Usually we work our way from the bottom up, so you meet your physical or your physiologic and survival needs first before you can move on to safety and security. And then these needs have to be met before love and belongingness. That's usually how it goes. But it's a little bit different in mental health. So if a patient was homeless, then we may start from the bottom. The priority for this patient may be that he needs food and water and shelter and sleep. And then after these needs are met, we'd move up to safety and security needs and so on. However, maybe a patient is suicidal or they have self-harm urges. Their priority care may not be food and water. Their priority care may be safety and security. We need to keep them safe. We need to make sure that they don't harm themselves, that they don't kill themselves. So we may start out with safety and security needs first. So Maslow's hierarchy of needs does not work for all patients. Sometimes we do have to go out of order for priority of care. So moving on to the cognitive behavioral theories, one of the behavioral theorists was Ivan Pavlov. And you guys might have heard of him before, but he was the one that did the experiment that taught dogs to associate a bell with meal times. So he would ring a bell before presenting dogs with food, and eventually the dogs would salivate when they heard the bell. And this phenomenon is called classical conditioning. One influential behaviorist was B.F. Skinner, and B.F. Skinner studied operant behavior or conditioning. So he believed that behavior followed by a pleasant consequence is likely to be repeated, and behavior that was followed by an unpleasant consequence is less likely to be repeated. Cognitive theories. So Aaron Beck, he's known as the father of cognitive theory, and cognitive therapy focuses on the way people think and how their thoughts and behaviors impact that individual. So, for example, patients suffering from depression tend to have negative thoughts. And Beck believed that if negative thoughts were replaced with better thoughts, then they would start viewing themselves and situations more positively. Cognitive theory is used to treat depression, eating disorders, substance abuse, anxiety, anger, and loneliness. So let's talk about applicability of cognitive behavioral theories of psychiatric mental health nursing. Basing interventions on behavioral theories is widespread in practice and in psychiatric nursing. Just a little example, a lot of the patient education is usually derived from behavioral theories. In psychiatric units, behavioral interventions include privilege systems and token economies, and these are used to increase appropriate behaviors. So rewards or tokens are given to patients for good behavior. So for example, where I work, PRN, we have the privilege system. So a lot of patients will come in and they'll be on stage 0. So they don't really have very many privileges on stage 0. But if they gain weight, if they eat their food, then they can go up to stage 1, and stage 1 would give them an opportunity to have their electronics for 30 minutes. They may be able to participate in yoga class or dance class. And if they continue to gain weight and eat their food, they can move up to the next level, which would give them more privileges. So they may get their phone for a little bit longer. They may be able to go out on a day pass. I know where we have clinicals, my group has clinicals this semester. Some of the patients earn points for their good behaviors. So once they get so many points, they get to play the Wii during their free time. So again, the points and rewards are to encourage good behavior and encourage the patients to continue with those good behaviors. All right, developmental theories. These explain normal human growth over time. So Erik Erikson outlined the psychosocial developmental model that is most often used in nursing. And each of Erikson's 8 stages is organized by age and developmental conflicts. So you guys can read through these in your PowerPoint, and they're also on table 7.4 in your book. But these are good to know for nursing, and it will help you too with in clinical, just kind of understanding where your patient lies in some of these stages. All right, moving on to social theories. So family dynamics are the patterned interpersonal and social interactions that occur within the family, in the family structure over the life of a family. So family dynamics are based on systems theory, in which one change affects the total functioning of the system or the family. And there's formal and informal support. Helping patients in the recovery process means helping them identify supportive family and community systems. So the formal support systems are large organizations such as hospitals and nursing homes that provide care to the individuals. And the informal support systems are family, friends, and maybe even neighbors. And it's important that the patients have an equal balance between both the informal and the formal support. So interpersonal relations models, Hildegard Peplow, she focused on the nurse-patient relationship. One of her major contributions that is still relevant today was confirming that the nurse-patient relationship is the core of nursing practice. So Peplow theorized that the nurse-patient relationship must pass through 3 phases in order to be successful. So these 3 phases included the orientation phase, the working phase, and the termination phase. And we'll talk about those phases in the next lecture. The nurse-patient relationship involves an interaction between 2 or more individuals with a common goal. So in nursing, this common goal is to develop a therapeutic relationship with the nurse and patient in order to respect each other. And Peplow emphasized the importance of empathetic linkages, in which the ability to feel the feelings experienced by another person. And anxiety or panic is the most common empathetic linkages. So Peplow believed that if anxiety is not recognized, it will continue to rise and escalate towards panic. If you look at box 7.3 in your book, you'll see the different levels of anxiety, which can range from mild to moderate to severe, and then to panic. So Peplow also believed that anxiety was energy that arises when expectations that are present are not met. And the self system is another important concept by Peplau. And she defined self as an anti anxiety system and a product of socialization. So, first, an individual create perceptions of themselves through experiences they go through, and they can perceive themselves as either good or bad. So the good personification consists of experiences that are rewarded, which someone would sense as notable, and anxiety may be decreased or be at a low level. But the bad personification of themselves consists of experiences that are punished and can cause greater anxiety. So, how do nurses use theory in everyday practice? Well, they use it to organize patient data. They use it to understand patient data. They analyze patient data. They make decisions about nursing interventions. They use it for plan patient care. They use it to predict outcomes of care, and they use it to evaluate patient outcomes. So that is the end of chapter 7. Let me get chapter 9 pulled up here, and we'll go over chapter 9. And then, like I said, after chapter 9, we're going to go into the breakout rooms and do some activities. All right, so we're going to go over chapter 9, which covers communication and therapeutic relationships.
Somebody had a question in the chat, and I'm kind of curious what the answer to that is.
Hold on just one second. Was it about the other theorists?
Yes.
Okay, I would know the ones that I went over in the lecture. Does that answer everybody's question?
Yes.
All right, so first we're going to talk about self-awareness. And self-awareness is the process of understanding your personal beliefs, thoughts, motivations, biases, and limitations that could limit or hinder your nurse-patient relationship. And if we don't recognize our biases, it is going to impact how we interact or how we connect with others. So we want to try and avoid having biases about different situations. We want to know ourselves, and if we are not aware of ourselves and how we may respond to others, and if we're not aware of how we feel about individuals, then it could lead to a poor nurse-patient relationship. So there is a lot of stigma, which we talked about yesterday. A lot of times we do not understand mental disorders, and we don't understand how to react to individuals with different disorders. And then that could be a problem. And we're not going to be able to develop that nurse-patient relationship, like I said, which is very important. Because if we do not develop a good therapeutic nurse-patient relationship, we're not going to be able to effectively help our patients. So we have to know ourselves, and you guys have to know yourself. So it's very important to know yourself. You may have physical problems or illnesses that you have experienced or encountered that could actually affect how you interact with someone else. You may have been in some kind of traumatic experiences in your life that have left scarring where you encountered pain that could actually affect how you may interact with someone else that has experienced that same kind of trauma. So you have to be careful when you are interacting with individuals that have experienced trauma because you are at risk for re-traumatizing them if you're not actually healed yourself from a traumatic event. So we also have to look at our own prejudice that we may have. So look at some of our own cultural norms that are ingrained in us. So all of that is important, and that's why we need to know ourselves in order to develop that therapeutic relationship with our patients. So let's talk about the biopsychosocial self, and these are just some dimensions we can look at that could possibly affect how we as nurses interact with others. The patient perceives the biologic dimensions of the nurse in terms of physical characteristics, such as age, gender, body weight, ethnic or racial backgrounds, and other observed physical characteristics, which can all affect how we interact with others. Also, genetic makeup, illness, or unobservable physical disabilities may affect how nurses interact with their patients. The physiological state of a nurse may affect how he or she interacts with others. An emotional state or behavior can negatively affect the therapeutic nurse-patient relationship. So, for example, a nurse whose child is using illegal drugs and whose patient has a history of drug use or substance abuse may inadvertently project a judgmental attitude toward the patient, which could interfere with the formation of the therapeutic relationship. So the nurse needs to become self-aware of her understanding or become self-aware of her underlying emotions, motivations, beliefs, and determine how these factors shape her behavior towards her patients or others. A nurse's social biases can also affect the nurse-patient relationship. So although nurses may not verbalize their values to patients, some are readily evident in the nurse's behavior, the nurse's appearance. Other social cultural values that may not be evident to patients may include a nurse's religious or spiritual beliefs, and these beliefs and thoughts can influence how the nurse interacts with his or her patients. So self-awareness is a very important technique that we need to develop in order for us as nurses to have a good therapeutic relationship with our patients. So here's a question for you guys. Is the following statement true or false? Self-awareness is achieved primarily from feedback from others. What do you guys think?
think false.
Yes, it is false. So, self-awareness develops through introspection and self-examination. Feedback from others is important to avoid bias. So, in other words, self-awareness is primarily achieved by looking introspectively or spending time examining our own thoughts, feelings, beliefs, and biases. But sometimes we are unaware of our own personal biases and prejudice, and that we have about ourselves. And we may be unaware about our biases and prejudice towards other people, in which we may have to solicit feedback from others because we may not be aware of some of those biases until someone points it out. You have to be willing to change your biases and perceptions about others. And you also, and if a nurse realizes they cannot change their biases or perceptions, then that patient should be referred to someone who the patient can develop a successful therapeutic relationship with. All right, so communication. These are very important to note for when you go to clinical and you start interacting with your patients. These are very good to practice and good at and get confidence in while you're in clinical this semester. So there are two types of communication. You have your verbal communication and your nonverbal communication. So nonverbal communication is just as important as your verbal communication. The way we communicate spoken words to other individuals, depending on how we say it, it could solicit a negative or positive feedback. So the way we say things, we have to be very careful, because if you say it in the wrong way, it may not agree with the patient or the person we are communicating with, and it could solicit a negative response. So how we communicate verbally and non-verbally is very important. Non-verbal communication is usually gestures, expressions, or body language. So patients look at your body language. They look at your facial expressions when you're communicating with them, and vice versa too. So there is an acronym called SOLER, SOLER, and it can help you remember some of the nonverbal behaviors that would facilitate active communication or good communication with your patient. So S stands for sit squarely facing the patient. O is open posture, so your arms and your legs should not be crossed. L is lean forward a little bit towards the patient. E is having good eye contact, and R is relaxed. So that kind of helps you remember some of the good nonverbal communication techniques. So therapeutic communication is an ongoing process of interaction in which meaning emerges. So when you communicate with someone, it is going to solicit some type of feedback that has meaning to it. And effective communication skills, both verbal and nonverbal, are building blocks for a successful relationship. So therefore, the nurse-patient relationship is built on this therapeutic communication. All right, so these are principles of therapeutic communication. Number one, the patient should always be the focus of the conversation. We never talk to patients about our own personal issues. The patient is our main focus, not us. So if a patient does ask a personal question, then the nurse or the caretaker, they should determine the underlying reason of why the patient wants to know or why the patient asked. Then the nurse can determine if he or she wants to disclose that information. However, it is important if you if you do end up disclosing information, try to gear the conversation back to focusing on the patient. Attitude should always be professional and non-judgmental. We should never judge a patient if they're having thoughts of harming themselves or if they're going through psychosis, we shouldn't judge them. We should acknowledge their feelings. We need to be accepting of them, and we need to help them explore why they're having these thoughts. Why are they having thoughts of harming themselves? And we cannot judge them because of that. Self-disclosure is rarely used. The only time you would self-disclose information about yourself is if it could possibly benefit the patient. So maybe you went through some type of loss. Maybe this patient is very sad and depressed because they have lost someone too. So at that point, to give some insight that each day gets better. I lost my mom, but each day gets better. That could help them. And it could also give them hope. And it could also let them know that they're not alone, that there are other people that have actually gone through the same thing or same type of event or trauma that they're going through now. Again, you have to determine how much personal information you're going to disclose or reveal to the patient, but it should benefit the patient, especially when the patients are really struggling with certain situations. And if you have been through the same thing and you were able to overcome and you can share that information with them, if you think it will benefit them and lift them up and give them hope that they can make it through their situation. And then advice. We don't give patients advice. We help them explore options, because if we give them advice and it does not go the way they planned, then they are going to fault us for it. So we don't give advice to patients. Social relationships. We need to maintain professional boundaries. We should not develop friendships or relationships with our patients. This is very inappropriate. So you have to maintain professional boundaries. You can't cross over because it's going to cause problems later on. If you have a patient that you personally know, you still have to be professional. You shouldn't run up to that patient and say, "Hi, Sally." You should let the patient identify you first. Patient confidentiality. It's very important not to share information about the patient with unauthorized individuals, unless, again, we're talking about duty to warn, or that the person is wanting to harm themselves or someone else. So in those instances, again, if the patient is threatening to harm themselves, harm someone else, If they make a comment that they're going to hurt themselves or someone else, then we can alert other people. We can alert the person that they have made a threat of harming. You can also tell their family if they're at risk for harming themselves. When you are communicating with patients, you need to make sure that you are communicating on a level that they understand. So you need to be assessing what level of education they have or what their intellectual status is. Your rationale, especially when communicating with people with mental health needs. We're trying to gather enough data and get enough information for us to be able to help them on their road to recovery and help them deal with their symptoms that they're experiencing. Avoid changing the subject during a communication exchange unless it is in the best interest of the patient. So, for instance, if you are talking with a patient that has experienced some kind of trauma or abuse, and you want that individual to talk about it, or you ask them if they've ever experienced any type of abuse or trauma, and they become silent about it, or you notice that they're becoming anxious about it, at that point, so if they do become silent, at that point, they're not really sharing information with you. And if you do notice them becoming anxious, they might, start panicking or maybe they're being re-traumatized. And in that instance, you may want to change the subject. You don't want to re-traumatize them. So that's another reason why you may need to change the subject. If you notice what you're saying is traumatizing them, again, you may need to change the subject. All right, this is just another slide talking about communication, and we've already talked about these. All right, so let's talk about some communication techniques. And you should start this slide because you will see some of these communication techniques come up on your exam. So let's talk first about acceptance. Why is it important to be accepting of patients? Or why is it important to be accepting of what patients are saying?
So they don't feel like they're being judged.
Yeah. Also, too, they know you've heard them. They don't feel judged. Examples, when the patient knows you are accepting of what they're saying, you may nod your head. You'll say, yes, okay, I'm following what you were saying. But what is the rationale behind that? Because an accepting response indicates to the patient that they are being heard. You're not judging them. Even your facial expressions, you need to control that because they do look at that. Even if you have a mask on, I would still practice having appropriate facial expressions. Confrontation is another verbal communication technique. So when you are confronting a patient about something, you do need to do it gently. You need to take baby steps because actually what you are doing is presenting the patient with a different reality.
Leg injuries in dogs are pretty.
So you're presenting the patient with a different reality of the situation. So for instance, you may have a patient that states, my best friend never called me but you know that that's not true because the best friend has called several times to speak to that patient. So you'll approach this cautiously because you do not want to appear as judgmental or have a judgmental attitude. So you have to use caution when you are confronting a patient. Another example is you have a patient that is taking more blood pressure medication than they need in order to get attention. So you want to confront them and state to them the reason why your blood pressure is continuously low is because you are taking more medicine than what you need to take. So again, you want to be gentle when you confront your patients. Doubt, when you use doubt, when you doubt someone, you are actually expressing or voicing doubt about their particular situation. So you need to be careful when you use doubt with a patient. You really do not want to do that, but it is used when the nurse wants to guide the patient towards another explanation. So you use it when you want to, again, guide that patient towards other explanations. So for example, the patient may say, "My best friend hates me. She never does anything for me." And then you can say, from what you've told me, that doesn't sound like her. When was the last time she did something for you? Interpretation. When you use interpretation, you're actually putting into words what the patient is actually implying or what they're actually feeling. It is used to help the patient identify or understand their thoughts or feelings. So when you use interpretation, you really want to help the patient actually identify what they're actually feeling about a particular situation. Observation. We always want to observe our patients. When you observe your patients, you're actually assessing their behavior and their response to certain situations. So, for instance, you may have a patient who suffers from anxiety. To explore more, you may say to that patient, "You appear to be shaking. Would you like to talk about why you are shaking?" So it is used when a patient's behavior is very obvious to you or when a patient is displaying emotions nonverbally. Open-ended statements. So we use open-ended statements and we use them because they are inviting the patient to actually give more information. So we may say, "Tell me more about what you have experienced this week." You're opening up the conversation to get more information. Close-ended statements or questions that are asked, they just have yes or no responses. So you're not really getting a lot of information out of your patient. They're not really able to express how they're feeling so much with close-ended questions. It's just yes or no. So for instance, if the nurse asks, "What does trust mean to you?" or trust means what? So you're wanting to get more information, you're exploring, you're trying to get more out of that conversation when you use this open-ended question. Again, they can't just say yes or no. They're having to explain, they're having to use sentences. Reflection. So this is another therapeutic communication technique. So you're actually redirecting that idea or a topic of that conversation back to the patient for clarification of important feelings, emotions, and experiences. So it gives the patient permission to have feelings they may not realize that they're having. So it is used when the patient is trying to get the nurse's approval or they're trying to see if the nurse has any judgment towards them. So reflection helps the nurse maintain a non-judgmental approach. So to give you just an example, the patient may ask, should I take a pass to go home this weekend? So to use reflection, the nurse would respond, should you go home this weekend? Because you do not want to give the patient advice, again, about going home for the weekend or sound judgmental about their ability to have a successful pass to go home. So your goal is to have the patient reflect on what going home means to them. So you are actually directing the patient's thoughts and feelings back to them. So it is going to encourage the patient to recognize and accept their own feelings. And that's what it is actually doing. It is allowing that patient to reflect on their own feelings. Restatement. So when you are restating, you're repeating the main idea expressed by the patient. So you are going to repeat back what the patient has said as close to possible and nearly in the same words. So restatement lets the patient know that he or she communicated the idea or the thought that they are trying to express effectively. And this will encourage the patient to continue in the conversation. Restatement will also help the patient clarify to the nurse what they're actually thinking or what their thoughts are, because when you restate back to what the patient has said, and if it is not accurate, then the patient can actually clarify what they meant to say. Silence. So remaining quiet allows the patient to express themselves. When we are constantly talking and butting in, we're not giving the patient the opportunity to express themselves. And that is not going to allow the patient to be able to clarify information or to express their ideas. So silence is a great technique. It also lets the patient know that you're listening and you're giving them an opportunity to express what they're actually feeling. Validation. When you validate, you're actually clarifying your understanding of the situation. So you or the nurse would respond by saying, let me see if I understand. This is what you could say to your patient. So it is actually used when you're trying to understand the situation that the patient is trying to describe to you. You are validating, you're trying to understand. And there are some learning activities that I will post for these communication techniques that you can use to practice and study from as well. All right, some verbal techniques that block interactions and inhibit therapeutic communication. So advice. So we talked about this earlier. We do not give patients advice. We help them explore their options because if we do give advice about something, again, and it goes wrong, it turns out bad, then they may blame us for that and they may be upset with us. So we don't want to give them advice. Agreement. You really don't want to be agreeing with the patient because it is not going to allow the patient to be able to think about what they have said, nor does it give the patient the opportunity to change their mind about something now that you have agreed with them. So, agreement, you don't want to do that. The patient is going to be denied the opportunity to change their mind. Challenging the patient is also not good to do. When you challenge the patient, you are belittling that patient. You're actually injuring their self-esteem. So we do not want to challenge the patient. Reassurance. So telling a patient that something is going to be okay. We don't want to do this because we don't know if everything is going to be okay. When you make a reassuring statement, it may not be true. And the patient is then blocked from, again, exploring his or her feelings because we don't know if everything is going to be okay. Disapproval, judging the patient's actions or behaviors or situation. If the patient states to you, I'm so sorry, I'm so sorry I killed my mom. I did not mean to kill her. You wouldn't say something like, oh, you shouldn't be. That was horrible. That was a horrible thing to do. Or oh, you should be. That was a horrible thing to do. That is belittling the patient. So you need to avoid disapproving reactions. I also want to note here too, another blocker is asking the patient why. So like, why did you do that? Why are you feeling this way? Using why statements or why questions is not therapeutic because it's demanding an explanation. It also implies criticism and the patient can become defensive. So we never ask the question why or why did you do that? All right, so this next slide just shows you how your posture can reflect your attitude. The first example is a closed conversation. So you can see each individual is staring at each other with their arms and legs crossed, as if to say, I don't want to hear anything that you have to say. Whatever you say to me, I'm not going to process it. So we would try to avoid the closed conversation. The second example is open communication. So both individuals are engaged in the conversation and they appear to be listening to one another. Body language. So you need to be aware of your body language. Arms crossed tells the patient that you're skeptical of them. You really don't want to be bothered. It's uninviting to the patient. So the lady in the chair with her arms crossed across her body, her body language is saying to me that whatever you say, I'm not really listening, or I'm not hearing you. The person at the bottom, the way her body language is displayed is, I'm all that in a box of Cracker Jacks. Whatever you say to me means nothing. So these can be some negative body languages that you want to try to avoid when you're talking to your patient. Some other considerations to engage in effective communication is developing a rapport with the patient. So that is very important. You want to develop rapport with the patient to let them know you care about them and you're genuine and you're listening and you are concerned. So empathy. We need to put ourselves in the shoes of other people to try to understand what they're feeling or what they're going through. So being empathetic is very important because it can give you an idea of what that individual is feeling or what they are experiencing. So empathy can sometimes get confused with sympathy. Sympathy, you're just feeling sorry for someone, whereas empathy is having the ability to put yourself into that person's shoes and to be able to experience their situation. So a nurse may ask themselves, like, how would I feel if I was in that situation? So it is important to be aware of empathetic linkages when you are communicating with your patients, because a lot of times you may talk to your patients about certain things, about their anxiety levels, and then you may notice that you too may start to become anxious. So you have to be aware of your feelings as well. And when you are conversing with your patients, because sometimes you can dwindle over to their feelings. So you have to be aware of your own feelings and analyze them. Boundaries and body space zones is very important. Establishing personal boundaries is important because you don't want to cross over into any intimate boundaries with the patient. Some patients and some situations on the units, are not allowed to hug patients. You're not allowed to show them a lot of love and affection and touching them and things like that. So you have to make sure that you respect boundaries because sometimes they may want to touch you. So you want professional boundaries, and that's very important that you establish that. Also, in the nurse-patient relationship, there are 4 types of body zones. So there's the intimate zone, which is very close proximity to someone. There's personal zone, there's the social zone, and there's the public zone. And there's a picture of it on this next slide. So it kind of just gives you an idea of boundaries and how far apart from the patient each zone would be. All right, the next thing we're going to talk about is defense mechanisms. So why do you think individuals or patients use defense mechanisms? So we can use defense mechanisms. It keeps us from experiencing anxiety. Defense mechanisms keep us just again from feeling uncomfortable, feeling that anxiety. A lot of times individuals are not aware that they are actually using certain defense mechanisms. Some defense mechanisms become maladaptive when its persistent use interferes with the person's ability to function, and it interferes with his or her quality of life. So denying that you have a substance use disorder is not going to help you. It's not going to help you identify that your habit of using substances has actually gotten you into trouble. And so you'll keep using, and eventually the substance abuse affects your ability to function. Adaptive defense mechanisms. Actually, you're going to learn from particular situations. So you always want to evaluate why patients are using defense mechanisms. They will use it in a maladaptive way, or they'll use it in an adaptive way. So let's talk about some of the defense mechanisms. And again, you should probably start this slide. So the first defense mechanism is denial. When individuals use denial, they're refusing to identify that they have a problem. A lot of individuals who engage in substance use are in denial, and they don't think that their substance use is a problem. I see this a lot at work, where I work with patients with eating disorders. A lot of them deny that they have a problem. A lot of them deny that they've been dieting, and they deny that they're sick or malnourished. Even if they're like sitting there, like complaining of being dizzy, even if you show them that their labs are abnormal, sometimes they'll still even deny that they have a problem. So the individual is failing to recognize the implications or consequences of their action or their particular situation. Displacement. When an individual is using displacement, they're actually displaying their anger or directing their anger onto someone that is less threatening. So, for example, a child is mad at their mother for not buying them something. They may displace their anger onto someone else that is not as threatening, so they may be mad at a sibling. Dissociation. So you will see dissociation with individuals who suffer from PTSD. A lot of times they want to be in a different world. It's like spacing out. They no longer want to be in reality. So when they use dissociation, an example may be an adult relates severe sexual abuse experienced as a child, but does it without feeling. She may say that the experience was as if she was outside of her body watching the abuse. Idealization. This is used when someone is attributing exaggerated positive qualities to others. For instance, if they know someone is very abusive, they may talk about how intelligent they are. They're actually trying not to see the person's negative qualities. Projection. It's kind of, if you think about like a projector projects an image onto something else, like a screen or a wall. So when someone uses projection, they're actually trying to display their feelings and thoughts or impulses onto someone else. So they're trying to make excuses for their inappropriate thoughts or actions, and they want someone to agree with them. So just an example, maybe like a child that is very angry at their parent, but turns it around and wants to say, no, I'm not angry at you. My parents are angry at me. They're trying to make their parents be what they're feeling. And then there's realization, which is the action of attempting to explain or justify behaviors or attitudes with logical reasons, even if these reasons are not logical. So an example may be that a man's girlfriend broke up with him and he explains to his friends that leaving her was the best thing because she was beneath him socially and would not like his family. Reaction formation. This is substituting behavior thoughts or feelings that are opposite to one's own unacceptable thoughts or feelings. This is usually done in conjunction with their repression. So an example would be that a wife finds out about her husband's affair and she tells her friends that she thinks his affair is perfectly appropriate, when really she doesn't think that it's appropriate, and consciously she's very angry and she's very hurt. Repression is a process by which distressing thoughts, memories, or impulses that may give rise to unpleasant feelings are excluded from the consciousness and left to operate in the unconscious. So, for example, a woman doesn't remember being raped in the basement, but she does feel anxious when she goes into that house. So she's repressing her feelings. Splitting is a defense mechanism that you'll see a lot with patients who suffer from borderline personality disorder. There's no gray area with these patients. Everything is black and white. So they may say, like, the day shift is very nice, but the night shift is mean. And there's no in between. Sublimation is when an individual is channeling their negative thoughts or negative images or their negative feelings in a more acceptable behavior. That would be someone who wants to beat up their best friend, but instead of beating up their best friend, they would go into the garage and hit the punching bag. So they're actually channeling their inappropriate feelings into something more socially acceptable. Suppression is when you intentionally avoid thinking about a disturbance or an issue or an experience. That would be your individual that anxiously awaits their exam results, but goes to the movies to stop thinking about it. And then undoing. So you're undoing a particular thought or an unacceptable thought. You'll see this a lot with people who have OCD. They have obsessive thoughts of acquiring some type of germ or becoming dirty. So to undo that thought, they engage in compulsive behaviors such as hand washing or showering. Another example would be someone who abuses their wife. To undo the negative action of physically abusing their wife, they may go out and purchase flowers to undo what they did. All right, analyzing interactions. So process recordings, you should have talked about process recordings with your clinical instructors, and you will be doing 2 process recordings during this semester in clinicals. But they are important because they can help us distinguish the patient's thoughts and feelings through a conversation. There is a good example of a process recording on Blackboard under the clinical information tab. And in that process recording, you'll be able to pick up some common themes that the patient may talk about, or the patient may reminisce upon certain things that happened in their life. You'll also be able to identify communication blocks in the conversation, things that the patient is still reluctant to talk about. They will become silent or they'll change the subject. These are some of the things that you'll look for in your process recording as well. And you'll also be able to evaluate your techniques. Did you use good techniques? Did you use good therapeutic techniques? Was there a communication block that you noticed while talking to your patient? And this is an example of a process recording that was in your book. Again, there's one on Blackboard too that you guys can look at. All right, so let's go into the nurse-patient relationship. So the nurse-patient relationship is very important, like I mentioned earlier. We talked about Pepwell. She was the founder of the psychiatric nursing interaction. And that interaction requires input from all participants, and it should contribute to healing and growth and health promotion. So you always want that nurse-patient relationship to be very therapeutic, but in order to develop that therapeutic nurse-patient relationship with your patient, once again, you must know yourself. You have to develop self-awareness. And as nurses, we'll play many roles as a psych nurse during that relationship with the patient. So in the beginning, you're going to be a stranger. You're going to be a resource person. You're going to provide the patient with various information about their health. You're going to be a teacher. So you're going to be helping that patient identify learning needs and provide them with information to help improve their situation. You're also going to be a leader, and to be a good leader, you have to allow the patient to be an active participant in the planning of their care. So you don't want the patient to be totally dependent on you. You want that patient to be autonomous as well. So when developing the nurse-patient relationship, the first meeting is when you gather assessment data. You're going to be identifying the patient's strengths and weaknesses. And in the first meeting, you're going to be formulating a contract. Confidentiality is huge in that first meeting, and you have to establish trust. So this all falls under the orientation phase. And that orientation phase is going to be the first meeting with the patient. Again, you're going to formulate contracts, confidentiality, and trust. Sometimes you might not hit it off with that patient. Sometimes you may be able to develop trust immediately, maybe within the first 10 minutes. Sometimes you may not be able to develop a relationship. There may be some struggling or testing of the relationship. And at that point, you may need to withdraw from the relationship and have someone else come in and be that patient's main contact person. The working phase. In the working phase, you're going to be identifying patient problems and helping them problem solve. So if they have problems dealing with or managing their anger, you will help them develop techniques to deal with that. In the resolution phase or the termination phase, all problems, concerns, everything should be resolved at this point. You're ending the relationship. You never want to continue the relationship after the professional relationship has been ended or has ended. You're going to evaluate the goals to make sure everything has been solved or resolved and the relationship is going to end, but there is something that can happen in the resolution phase or the termination phase, and the patient may regress. So what I mean by that is the patient may start to have the same symptoms that they did when you first met them. And at that point, you may have to reevaluate and start all over. So even if you get to that resolution phase, when you get there, sometimes patients can regress all the way back to maybe even the orientation phase. So even before the orientation phase begins, there is another phase called the pre-interaction phase. That pre-interaction phase is when you are obtaining initial assessment or data about your patient. So it may come across in the SBAR that you're dealing with someone that is 26 years old, 8 months pregnant, and they're high on crack. So at that point, you're going to have to explore your feelings about interacting with that individual. A couple other terms just to go over that could occur during the nurse-patient relationship, again, would be transference and countertransference. So like I mentioned earlier, transference is when the patient displays feelings or emotions or certain behaviors that can be negative or positive onto the nurse. So maybe you or the nurse reminds the patient of their 20-year-old granddaughter who the patient truly adores. So now the patient is trying to formulate a more personal relationship with the nurse because she reminds her of her granddaughter. So the patient is trying to do things with the nurse, and at that point, there's no focus on the nurse-patient relationship. And then countertransference, again, is the opposite of that, and that occurs when the nurse is transferring his or her emotions onto the patient. So maybe the nurse has to engage with a patient that has a history of substance use, and this patient reminds the nurse of her father, who also suffered from substance abuse. And when he abused substances, he became abusive. So automatically, all of these old feelings are starting to resurface with the nurse. And she develops an attitude and displays negative emotions to that patient. These emotions can be brought up from negative or positive experiences as well. So maybe an example of a positive experience is a patient that reminds the nurse of her dad, who she loved and adored. And now she's spending more time with that patient, and she's doing more things for that patient, and she's ignoring her other patients. So again, these can also occur when engaging in a nurse-patient relationship. All right, so these are some strategies or examples of comparing effective versus ineffective dialogue. I talked about how important it is to make sure that you communicate effectively and respectfully with your patients. The way you say things can generate a different response. If you're yelling and screaming at the patient, or you appear to have an attitude with that patient, you won't get the response that you want. Motivational interviewing is huge for changing behaviors. Number one, when you are actually engaged in motivational interviewing, you have to access what stage of change that patient is in. And this is going to help the patient's decision-making ability. Motivational interviewing is a way to successfully help the patient make some changes. When you engage in motivational interviewing, there's some strategies that you will have to use to be able to enhance that patient's decision-making ability, especially when they need to make some more serious life-changing decisions. So for example, if they need to stop smoking, if they need to improve their diet, if they need to lose weight, there's different techniques that you can actually do to motivate them to change. But initially, you have to really make sure that you access what stage of change they're in. Because if they're in the pre-contemplation stage of change, then they have no intention of making any drastic changes. So you have to assess before you even engage in some of the strategies for motivational interviewing. translational relationship model, transitioning from one relationship to another. So we have to be very careful, especially when we're ending a relationship with a patient, and we have to refer them to other resources in their community. We want to make sure that we have actually reached out to who they will be interacting with next, and make sure that they have contacted and that they're aware of who they will be engaging with when the nurse-patient relationship ends. Telehealth is becoming the new way of interacting with patients, especially now with COVID, instead of interacting with them in person. So a lot of places have transitioned to that again now with COVID. So if you click on the link in your PowerPoint, you can review some communications with a person with bipolar disorder. All right, so some other non-therapeutic relationship things that could occur during the communication process. I talked a little bit about some of these already. But grappling and struggling, having difficulty reaching a common ground, coming up with a mutual agreement on how things are going to be done, deteriorating relationship. When you know the relationship is going to start to deteriorate, the following things are going to happen. So the patient will withhold information. They will start to avoid you or ignore you, and there will be struggles to understand what phase they will be in. So this ends the lecture. I'm going to give you guys about a 10-minute break, and then we're going to come back and do some activities in the breakout room. So come back around 12:55 and we'll do some of the activities.
Jen, are you you doing the groups?
I'm giving them a break and then they're going to do the groups.
Okay. Okay. I don't know what's wrong with my screen, but now I can't see anything. So I guess I don't know what's going on with it.
I think someone has to have their video on.
Okay. I don't know why they made those changes. You already have your rooms set up?
Yes, hopefully they work.
I hope so too. Hopefully it's saved. You won't have to go in and put everybody back in the breakout rooms.
Yeah.
I hope not. Okay.
I hope Bernadette can get her information or participants for her study. Sounds interesting.
Oh, yeah, I really would like to collaborate with them on some things as well.
Yeah.
And she's right. That's a good way of getting participants is to make friends with people that are can definitely participate in your research.
Yeah.
So I really need to be collaborating with her on some of the things that I have to do.
When I talked to her, she didn't say anything about having experience in mental health or anything like that. I just knew that she was a professor and that she worked with peds. I didn't know anything about mental health.
Yeah, there were a couple of faculty that took the pediatric um, mental health practitioner exam. They didn't do across the lifespan. They just did pediatrics because they worked in peds. Dr. Val Griffin, she also has her certificate to do peds mental health. So it was a couple of them that did that. Oh goodness.
All right, if you guys are back, can you just give me a thumbs up or let me know you're here so I can start the breakout rooms? Okay, cool, thank you. I'm gonna share my screen just for a minute. I'm gonna put you guys into breakout rooms, but if you guys, once you get into your breakout rooms, just have a leader of your group share their screen. And if you guys go to the week 1 folder, there's some in-class activities. So the leader can download the document and you guys can work on it. The leader can type your answers and then we will come back and discuss the activity. So I'm gonna hit the breakout rooms and you guys can accept it. But if you're the only one in the room, don't leave. Sometimes we have trouble doing the breakout rooms and I might have to manually put people in the room. So if you're in there by yourself, just hang out for 10 minutes and see if I can put the other people in your breakout room before you leave.
Are we gonna have to submit this somewhere? Like, should we all?
No, we're just gonna talk about it.
Okay.
It's just for studying purposes and for us to have a little class discussion. All right, George, do you see your breakout room?
Speak of the devil.
George!
We got George, Madison, Chelsea,
Yeah, Hunter.
Hunter.
Oh, so y'all are like pretty much the same, except
Yeah,
for
the only ones that
just me and Jacob.
are you and Jacob, yeah.
Damn, we got flopped around again this semester.
Damn, I was wondering if they'd just like slap you back in our group after.
Yeah, no, we got mixed up again. I mean, me and Jacob are still together,
Yeah.
but now it's like me, Jacob, Jake Melton, freaking. There's like 4 dudes again.
Oh, damn.
Wade,
Oh, that's a good group.
and then I can't think of Jonky. I don't know. I can't remember.
Oh, Thomas, you're so nice.
That was unexpected.
Natural born leader. What can I say? Someone's got to take charge here. Might as well be the most immature. All right.
And we got Hunter. Man,
The squad.
squad is back.
All right. So, a 48-year-old woman is admitted to a psychiatric inpatient unit for observation and evaluation after an episode in which she murdered her husband of 22 years, a well-known legislator, after finding out that he had an affair with his 23-year-old political assistant. Well done. The case has received tremendous media coverage. On admission, patient expresses suicidal ideation as well as homicidal ideation to plan to kill the lover. She also reveals that her husband has been unfaithful once before earlier in their marriage. When documenting the assessment, the RN includes that the patient expresses both suicidal and homicidal ideations with a specific plan. Should the information about the husband's past infidelity also be included in the assessment note? Explain your answer.
I feel like yes, because if she's homicidal, she could go and if she knows who that person is, she could try to kill her too.
I'm kind of like torn because she hasn't so she expressed to kill the the newest one. But if she hasn't mentioned anything about the previous one, I feel like it's kind of irrelevant towards the current case.
Well, she did. It says she reveals that her husband had been unfaithful once before.
Yeah, but she said she doesn't have a specific plan to like she has a specific plan to kill the new one. Not she doesn't mention anything about killing the old one.
And maybe we should check to see that the first one is alive.
Yeah,
Fair enough.
Yeah, we might want to make sure.
Yeah.
Maybe we should dig a little deeper and see if this first one is indeed still alive.
Well, so should check to see if. So we.
That was partially a joke.
Well, I know we're not. I'm not actually running that.
See if she randomly, tripped and fell in her kitchen on a knife.
Right.
So.
I don't know. I think it's worth mentioning.
Yeah, I don't think it's a major piece, but I think it's definitely worth saying.
How's that?
Sounds fair.
Prior mistress. All right. Should the RN notify others of the patient's homicidal thoughts and specific plan for the political assistant with whom the patient's husband had an affair? By others, does she mean like in the staff? Or
that person.
So
I feel like that's
I don't know like the protocol of that. I feel like if you have a patient who has like homicidal ideations that staff should know.
Yeah, all staff should know, and the police have to be notified
Yeah,
So you want to watch your back a little bit.
because they have to notify the person that like could be killed.
Look at us, so cohesive.
all right. 85-year-old male patient in a nursing home who has hypertension, diabetes, and a long-standing post-traumatic stress disorder secondary to being conscripted at the age of 17 into the Nazi army toward the end of World War II, refuses to take his medication. Third day of medication refusal, the patient is delusional that he's being held a prisoner of war camp. His blood pressure is elevated to 152/96, and his fasting blood glucose is 410 over, 410. RN knows that the patient must receive his medications or risk serious medical concerns, possible death. What ethical dilemma?
Can we please talk about how Madison left?
She left?
oof.
I'm assuming it wasn't our Madison, because
It was.
She lives in the cornfield. She probably just got booted from her connection.
that's actually pretty accurate. She does have rough internet out there. I think isn't the ethical dilemma that the patient is refusing treatment?
Yeah, he's refusing treatment despite it being a health concern.
The problem is with that, with the intervention. So I'm thinking, I don't know what the biosocial model is, but I do know that with instances like this, like if they're not in the right state of mind, isn't there interventions that the nursing staff can do?
They can see if he's got anybody that
like advanced
can make basically that can make shots for him because he obviously can't.
In this case, you just
Advanced directives or whatever.
What was that one? It's called. It's not an advanced directive, but it's
verbal power of attorney.
Yeah, power of attorney.
Can you guys hear me?
Yeah, dude.
Hey.
It took a
What
little
to do?
computer work, but I finally did it.
I mean, you're like really soft, but I can hear you.
It'll happen.
Hey.
Don't worry, it'll warm up hopefully.
Hey, you're warmed up already, I think.
Oh, a little bit.
I'm gonna be honest, I'm pretty confident in this class. It seems really simple.
Just wait till the next exam. Crazy.
Amanda knows this, so I'll inform you guys because I know you guys as well. Who else is in this Zoom before I say this? Just us?
Yeah.
I've been recording all of the lectures, like voice recording. So if you
Lit.
guys, want to start like a Google Doc share, I can just start posting them in there. It doesn't have the screen recordings, but it has her voice. So
I've been recording them on YouTube. I've been streaming it, so it's also posted there as well.
oh shit,
So
we're just
Nice.
even now, we're being streamed.
Hello, YouTube.
Tread lightly.
All right. Well, so an RN is working with a 34-year-old patient admitted after surgical removal of a ruptured spleen and open reduction and kernel fixation of her left femur after a multiple vehicle accident in which she has been determined that her husband was driving under the influence of alcohol. Her husband and a passenger in the second car were killed. In her acute grieving state, the patient verbalizes excessive guilt, stating she should never have let her husband drive after drinking at a party earlier in the evening. Patient tearfully sobs, "I've taken away my baby's father, lost another family, their loved one, and caused my terrible grief to everyone. It's all my fault. Yada, yada, yada. Everyone must hate me." Nurse responds by crossing arms over chest and looking away from the patient. "Well, that's wrong." Replies, "What a difference it would have made to a lot of people if only you had done that. Of course you're upset with yourself."
What the hell?
Holy shit.
She's a monster.
Wow.
I think
You should be ashamed of yourself.
I don't see anything wrong.
Savage.
What techniques that inhibit communication is the RN demonstrating?
Closed off.
All of the above.
Wait, let's start with the closed posture. Sure.
Yeah.
Let's just slowly dissect this.
Slowly work our way down.
Non-therapeutic language.
Judgment.
No shit.
I don't know how to spell therapeutic.
Autocorrect, dude. Just type it out and it'll correct you. Hey, there you go. Bam. Nailed it. Nailed
So
it.
wrong. The autocorrect can't even help you out.
They're like, he's on his own.
Chief, I'm not sure what you were going for there.
Let's see here. Am I missing it? Disapproval.
I don't remember what it's called, but the way she like referenced her past.
Oh yeah.
Her past.
Fuck it. Reflection. No, it's not. Is it reflection?
I don't think so. Let me see.
I think advice, because she says she finishes off with only if someone had taken the keys away from the drug driver. Oh no, that's what you're talking about. Agreement, because she's saying, of course you're upset with yourself. Oh, that one you autocorrect, you fucking whore. Okay.
Self-disclosure.
Oh yeah.
That's the part where she talked about the drunk driver in her past.
Confrontation.
Yeah, a little bit.
That whole that is just very confrontational. All right. Is that it?
I think so, yeah.
Oh, this group is the best. This better be our same breakout room group every time.
Probably not, but I hope so.
We'll figure it out.
I don't know. I'm kind of shocked that we actually did it.
Yeah. Because
I think
we
this
realized
one-
we all got put in the same group together.
Yeah, I think this is one of the first breakout rooms I've participated in.
Yeah,
where more than one person talks, or that actually anybody says anything at all.
Usually, like last semester, it was just like she would do the breakout rooms and no one would say a fucking word.
Well, most of the time I was with people that I had like no idea who they were, or like had seen them in class like one time.
Yeah. It's amazing.
Unless you got in a group with Jake and then he just talked to himself and did it.
Well, I'd be in a group that I know people and still nobody'd say a word when I said something. It was so awkward.
All right.
Does anybody know anything about this research course we're supposed to be taking Monday?
No.
No.
All I'm thinking is, I'm assuming it's a lot of papers and stuff, which means there's probably not a final exam.
Yeah, my sister took it last semester, and she said it was extremely easy, like a 2 out of 10 difficulty rating. And yeah, you just
I just
Probably
don't
like
like
a
that there's
paper,
only
so-
2 tests and a final.
yeah. It does say there's a lot of quizzes though, but
I imagine it's a lot of like reading and you might have to
Yeah.
do like small papers or whatever
Because
each
what
week.
made you pick up a publication manual for APA. So I have a book on how to write APA format. Yo, George, did I ever tell you what my final grade was in OB?
what was it?
92.6. She didn't round it up.
Oof.
Why didn't she round it up?
I thought she had to.
Yeah.
Nope. I literally, like, my final grade was 92.6.
I would have
Thomas,
said something
you
because I'm pretty
emailed
sure
her?
she has to.
You should email.
I'm gonna text her.
I would text her. Dude, beware, because she might send you a novel about how that's not the chain of command you should take.
Yeah.
We had I don't know if did you guys have Kelsey last semester?
But yeah, I was in your class.
Amanda and Cameron.
Honestly, I'm impressed with that with like 92.6. That's a grinding semester.
Well,
That class was tough.
she got mad at me because, like, if I was in like a dire situation, like I would just text her instead of like emailing her because texting is a lot quicker. And then literally everyone in our entire clinical group would text her. And then I was the only one that got yelled at for texting her. She like
But
literally
yeah, the thing is about her email, she never emailed back hardly.
about how it was inappropriate that I was texting her. Meanwhile, George is texting her, Chelsea's texting her.
Had a long string of conversation with her.
Hey, George texted her Merry Christmas on Christmas.
No, you didn't.
No, he didn't. But she does pop up on my suggested friends on Snapchat, and I'm always tempted to just hit add and just see what happens.
I feel like this
George,
test.
did you go to Home Depot this week?
Yeah, I went there yesterday actually.
No, you didn't.
Uh-huh. Didn't buy anything.
Did you
just
sniff the
sniffed
sink?
stuff. Yes. I don't know. I was tempted to sniff the sink at the mental hospital part whenever we were touring rooms. I was like, it wouldn't be that funny. It'd just be weird.
Bruh.
I told this.
Sorry,
to
fill me
Thomas,
in.
He didn't believe me.
I damn well believe you because I've spent years with George now. Nothing you could tell me about George would surprise me.
True.
Are we like supposed to? Are we gonna like go back into the group?
Yeah, they just take forever.
Yeah, they're not as smart as us. I mean, they probably put more than one sentence answers.
Well, they're overachievers. It's fine.
I'm just proud of our group for doing it.
I'm kind of curious of how our clinical is going to work with all that stuff we got to do.
Have you done your log for this week yet?
No, I'm going to do it like right after this class.
I'm gonna do it tonight. I gotta go to the doctor, which is at fucking Jefferson Barracks. So
Hey,
I'm gonna go there and just be like, I'm here. Just show my pass at the gate and be like, I'm official.
trust me, I'm a professional.
I have a badge. Mary was like, when you're getting into records, make sure you don't get into your own. I'm like, I'm not gonna do that. I can do that from home. I suppose no one said anything about my Kenzie's forehead.
I was about to ask, honestly. I was like, whose forehead is that? Because it's just really random.
It's one of, yeah, forehead.
I sent you a snap about that.
Yeah.
I was wondering
You
how
did,
she
and so
felt
did
about it.
Kenzie. Like every time I log into Zoom, I just see my own forehead. It's not even on my picture.
So can I be added into the clinical group chat?
Oh my god. Yeah, what's your phone number?
Bitch, you have my phone number.
Fine. I'll add. I can add. Which
We
one?
just want to make a new one since we have like 2 people, I
Yeah,
think, in our
probably.
current chat that aren't even in our clinical group anymore, I think.
Yep, I'm gonna leave it up to you guys. I believe in you.
I think Kara is still in our chat, isn't she?
Probably. If we haven't changed since PEDS, then yeah, she would still be in it. Because I don't think we created a new one.
Imagine how annoying that would be.
Just like random, like, no shit conversations in chat that have nothing to do with you.
Oh no, there's only 5 people in our clinical group chat.
Actually, I think the only person that's in there that isn't normally in there is Desiree.
Yeah, so that's just because she got through into a different clinical. I'm gonna create a Google Drive doc so I can post these lectures, and then George can post his.
Yeah, I totally napped through the entire class so far today.
I mean, honestly, I feel like 90% of what we've gone over so far is like common sense, like being a like non-asshole, basically.
How do I storage?
And we've literally learned about Freud so many times that I was like, I'm not listening to this.
Oh,
Yeah, I mean, besides that, it was basically like be nice to your patient.
Looks like a psych
Don't like
class. a
say.
little bit.
yeah, it does.
Like a psychology, sorry.
So my drive.
Cameron, you remember that psychology class?
With what's her name?
Yes.
What is her name though?
Oh, Stacy.
Stacy.
Stacy Adams.
Oh, Stacy Adams. Were you in there with me?
Yeah.
Where'd you sit in relation to me?
So I was the second row closest to the door.
Yeah, I don't remember. Sorry.
Only reason I remember is because one day I had to come over and sit by you for some reason.
Poor Cam.
And we had chem together.
We had Kim together. Sure.
Who was
Who's
that
that?
man that was next to you? And what happened to him?
Oh, that was Chancellor. And he was going for I don't know. He snapped me the other day. He was cool. He was going for construction management. I don't know. He probably graduated. Big country.
All right, I'm uploading all these. I just don't have my share a drive.
Cameron, where you got clinical at?
Over at DePaul.
Ah,
So a 45-minute drive. Where you guys at?
the VA out at
Jefferson Barracks.
Jefferson Barracks. Yeah,
How far is that?
About 30 minutes.
yeah, something like that.
How's the
Definitely
hospital?
drive out to wherever we were for like that 2 weeks of OB.
Oh, St. Luke's. Yeah, my mom works out there. It's like an hour drive.
I would go.
Each way.
God, that was.
Yeah, that was a bit of a drive.
You say it's the VA?
Yeah.
How's
Well, it's
that?
it's not. Yeah, it's not bad.
No.
It's very a boring hospital.
I think it depends on which area you're in, because like there's one area that seems almost like just like a general floor, and then we went to the other wing, and it was simple and gloomy.
Yeah. Definitely like a. We don't have like a pediatric wing. We just have like a geriatric and an adult wing.
Does it say is it broken up like men's, women's, adolescent, or?
No, it's
I don't think
broken up.
so.
I think it's broken up to just geriatric and then like regular.
Yeah, and the regular wing is literally so dark. They don't have any of the lights on to decrease stimulus and everything, and it's like you literally go in and it kind of looks like a prison.
To be honest with you, it seems more of like not even really geriatric and adult wing. It almost looks more like a severity.
Yeah.
Wings based off of severity.
What time do y'all go from?
Like 8 to probably 2 or 3.
Yeah, same.
But then we have to come back and Zoom
Yeah, she takes
for
the
the conference.
she takes the Zoom. But she seems to take like the clinical a lot more serious than any of the other ones we've had so far.
Who do you have?
Mary Boyd.
Yeah, Mary Boyd.
Apparently used to be the assistant dean for the nursing school, and then she retired, and now she's been at this current job since 2007. So pretty much she's ancient.
I asked like I'm gonna actually know who it is.
When
Like
I said Mary,
ancient.
first time I saw Mary, I was thinking that Mary that taught us over in like Bluff Hall. Wasn't that her name, Mary?
Nancy?
No,
Furlow?
what did Mary? No, Mary was the younger one, wasn't she? Or was that Amy?
I think that might have been Amy.
Who was the younger one that taught us in Bluff? Nancy was the older one that taught us like our very first semester.
Yeah, she was my OB. She was my OB instructor or clinical instructor.
Oh, nice. I'm still waiting to get Tara back.
We still have a chance.
For what?
Just anything.
Thomas also thinks that our instructor has a little bit of dementia.
Believable.
She taught me. She told me one thing like 3 different times throughout our clinical, like just the tour. I'm like, all right, lady, chill. All right, if I post something in here, will she see it?
Everyone will see it, yeah.
But like, will she? Oh, ooh, yeah. How do I know?
Oh, we're coming back.
Hi, friends.
Bye bye.
Came off.
All right, better? Can you hear me now? All right, let's go over some of the answers you guys came up with for these scenarios. All right, so let's start with the first one. It was about the 48-year-old woman. And the first question was, should the information about the husband's past infidelity also be included in the assessment note? Group 1, what did you have for your answer?
We put yes.
Anybody else have a different answer? Why did you guys put yes?
We mostly put yes because that was the part of the precipitating event that caused this current little break that she was having. And so when actually assessing it, we need to understand the root cause of what's, what triggered her the most.
But would you be breaking trust or confidentiality by telling her husband this information?
Wait, I thought it was telling it like an S-bar, like when you were doing report to the next person.
Yeah, just
that's how I also interpret the question.
Oh, this. So.
Isn't her husband, like, didn't she kill her husband in this?
Yeah, her husband's dead.
Yeah, she did kill her husband. So it actually would be no. The past infidelity should not be included in the patient's chart because it does violate patient's privacy. And the privacy refers to that part of a person's personal life that is governed by the society's law. So you should not include that in her assessment notes.
I feel like the only way, or the only reason that we were thinking that you should was because if she's homicidal, then maybe she'll go for this other lady too.
Then you would tell if she was going to harm herself or someone else, then yes, that's when you would. But it never did say that she did plan to harm anybody else.
I thought it did.
It says she has a specific plan to kill the political assistant, which is the second mistress. So we
And suicidal ideation.
But the question's just asking about the husband cheating on her in the past. It's not asking about the actual murder. It's saying, would you include in her chart that the husband cheated on her?
Yes.
No,
Yes.
I don't think you would.
I guess I'm still having a hard time rationalizing that, because just from a systemic aspect of what brought them into the hospital in the first place, I guess that's where I'm going with that. I see where you're going with that in terms of like an instructor explanation, but I guess I don't know.
I also have a question.
I've seen this type of thing happen at work, and they often put this in the chart because it permeates throughout who's allowed to access and receive information about them.
Also, since it says like, well, I mean, I'm assuming we have to report because she has the ideation of the specific plan toward the assistant. Do you have to have like a it's just this random woman to anybody else who doesn't know that she murdered her husband because she was cheating? I don't know. I guess I just don't know what exactly you would put in there versus what you would not.
So if it is going to violate their privacy, then you would not put it in there.
Okay.
So let's read through it and discuss it more, because it sounds like some of you guys are still a little bit confused. So a 48-year-old woman is admitted to a psychiatric inpatient unit for observation and evaluation after an episode in which she murdered her husband of 22 years, as well renowned legislator. Wow, I can't read. After finding out that he had been having an affair with his 23-year-old political assistant. The case has received tremendous media coverage. Upon admission, the patient expresses both suicidal ideation as well as homicidal ideation with a plan to kill her husband's young lover. She also reveals that her husband had been unfaithful once before, early in their marriage. When documenting the assessment, the RN includes that the patient expresses the homicidal and the suicidal ideations with a specific plan toward the 23-year-old political assistant. So again, the infidelity, that's more of a privacy issue. Now they would need, like it said, they do still need to put the suicidal ideation, the homicidal ideation, because those are both harmful to the patient and to herself. But the husband's infidelity is not something that would necessarily, it's not harming the patient or anybody else by telling someone that her husband's been that has had infidelity. So does that make sense? Like the infidelity isn't what would tell someone that the patient is homicidal or suicidal. Her actual feelings of having suicidal, or her actual thoughts of harming someone else is what's actually at stake here. Like that's actually the important information, and that's actually things that do need to be expressed, and that's something that would warrant her privacy, and her breaking that privacy. But the infidelity is just kind of like a personal experience that's not necessarily harmful to her, if that makes sense.
So do we never have, say we're doing future assessments, we don't have to actually put in what led to the suicidal ideations and homicidal ideations. We just have to put in that they have those. Because like in this instance, like I'm just confused because I feel like the infidelity led to these ideations and the murder.
But I don't feel like that's important, knowing what caused her to have those ideations. It's more important that she's having the ideations. And then that is something that you need to address, not the fact that the reason of it is the infidelity.
I feel like you do need to address why, because you have to tailor individual treatment.
Yeah, that gives into her motives.
Also remember too that there is a difference between privacy and confidentiality as well. So just note that too for your exam. Tracy, do you have anything to add? She might have stepped away.
Can you explain the difference between confidentiality and privacy?
So I remember I gave you guys kind of that example in class where if you walk by a person's room and you notice them reading a book on managing bipolar, actually witnessing that has broken privacy. But if a patient says, don't tell my wife, like actually telling someone else that I'm ill or that I could die from this, actually telling someone else when the patient said not to tell someone else will be breaking confidentiality. Does that make sense?
Jennifer, could you clarify like what the assessment note is? Because when I read that, I was thinking more like on like MedSurg and other things where we write like a description of what happens. So I was assuming background information was needed. Within mental health, is that similar or is it different?
It is a little bit similar. A lot of your assessment notes will be about the patient's behavior, about their interactions with the staff throughout the day. Maybe if they've had poor behavior or they've had good behavior, that would be something else to assess or put in your assessment notes. Like throughout the shift, if something went wrong, if they had self-harm urges, that would be something to put in your assessment notes. Maybe you checked in with the patient and you gave them coping skills and the coping skills worked, would be something else to include in your assessment notes.
Okay. And then so like the situation, is that more in like the document that's like history and background that you find on medical histories?
So their history and background, yeah, like if, like again, if they have a history of bipolar disorder, that's going to be found in your history and your chart. Or if they've had a history of aggressive behavior, that would be something that you would find.
Okay, so it's like a separate document that talks about that, and the assessment note is more of what's currently happening?
Yeah, kind of. Assessment notes too can also be done by therapists and social workers too, to write about the behaviors that they've experienced during group or during their time in therapy.
Okay, thank you.
All right, let's move on to B. Should the RN notify others of the patient's homicidal thoughts and specific plan for the political assistant with whom the patient's husband had an affair? Group 2.
Our group said yes because of duty to inform.
Correct. All right, the next scenario. What ethical dilemma is the RN presented with?
I said that the dilemma between autonomy and beneficence. So like letting him be able to have his rights, but then also like preventing harm or not doing harm by not giving him his medications.
Correct. Did everybody catch that? So the dilemma was between autonomy and beneficence. So you do want the patient to have a choice with their treatment, but at the same time, the nurse felt like it would benefit the patient to have his medications. Okay, using the biopsychosocial model, what possible interventions might the RN implement? Group 3, what did you put on here? Or group 4, what did you put?
I'm not sure what group number we were actually, but I didn't know really what kind of interventions to do, because can you really force them to take his medications, even if it would benefit him more?
What about not forcing, but what about maybe teaching?
So, sorry, go ahead. Our group we said, you want to check for like a power of attorney or any advance directives to see if he's written any out in a conscious state of mind, because as of right now, he's not in a conscious state of mind. So this may not be the first time he's experienced an episode like this, and there may be some legislation somewhere that says what to do in an instance like this, or there may be a person like a family or friend that just knows that can make these decisions while he's not in the right state of mind.
Yeah. So you could look to see if he has any documentation about when he's delusional or disoriented about taking medications. Again, you could provide education to the patient. Again, just teaching him about what the medications are used for, why he might need it, and any negative consequences if he doesn't take the medication.
I have a question.
Yeah.
What if he's never gotten delusional and stuff before, and I'm sorry, I lost my whole train of thought. He needs to take his medication, but there is no, like, he doesn't sign something that, or says, like, if I'm unable to, or if I am, delusional, whatever, that you can force me to take my meds. And you also can't talk him down because he thinks he's at a boot camp, or at war camp, I'm sorry. And you can't talk him down and stuff, but, like, for his sake, he needs to take the medicine or he will die.
So you do have to prove, again, if the patient is competent and can make decisions for himself. You might have to have a doctor or a court order stating that he cannot make those decisions for himself before you're able to give him his medication, even if he refuses it.
So what happens if, like, in this situation, his blood pressure was extremely high, and his glucose was high as well? If this is something that could, like, we don't have time to do all of those things to get a court order and all of that, then what do you do? Because this could kill him before that was done.
A doctor would, again, have to rule to say he was competent or incompetent when making those decisions, and then they can go from there on how to treat him. If he is competent and he's refusing that, then you just have to educate him on the consequences of what's going to happen because he's refusing it, and you need to document that he's refusing it. But if he's not competent and the doctor rules that he's not competent, then there's steps that you can take to still give this person his medication, because if he's not competent, then obviously he can't make those decisions for himself because he would die, in which case, after those steps are taken, then yes, you can provide the medication to the patient so that he can get better. That makes sense?
So basically it just sounds like you're describing implied consent once, everything's been ruled out, because more often than not, in the experience that I've had, it seems more like most people don't have POAs, so it kind of just gets escalated to the doctor deeming fit, and then just immediately aggressively treat. So, cool.
Yep. All right, let's go to the last scenario. What techniques that inhibited communication does the RN demonstrate?
So she's starting off with just a closed posture with the arms crossed over and looking away from the patient. She's using non-therapeutic communication like disapproval. She's agreeing with the patient, saying that, of course, you're upset with yourself. I think she just went a little too far into like the self-disclosure with the whole drunk driver killed my brother 3 years ago thing. And then just the overall tone of the conversation just seems kind of confrontational, like not therapeutic at all. She's like talking down on the patient versus treating the patient.
What else did you guys notice?
Lack of eye contact.
I feel like she has some anger.
Was she judgmental at all? Did she have any empathy towards the patient?
Definitely judgmental.
What
She's
about-
kind of using her experiences, like this person experienced that, and she's using her experiences instead of just focusing on the patient. She's kind of focusing more on what she experienced than what they did.
Yeah.
She also kind of like falsely assured her feelings, you know, like reassured. She was like, yeah, I feel that way too. You can't really do that. So
What about some of the nonverbal communication? We said something about eye contact. What else?
And crossing her arms.
Crossing her arm. She's not making great eye contact. That's all I have. I'll post these answers on Blackboard for you guys as well. But if you guys have any questions, you can stay after class and I'll be happy to answer them. I do want to make a few announcements though. You do have your exam 1 next Friday. So everything that we talked about this week will be on your exam. We'll start some lectures on Thursday, but the lectures that we start on Thursday will not be on your exam. It's just everything from this week. So on Friday, you'll have your exam. You have to log in at 11 a.m. To take it. Please don't forget to do your COVID screenings for your clinical as well. So make sure you're doing those on time because there are consequences if you don't do them on time.
I would probably suggest the Sierra Silver because it brings in both.
You guys are ready to go, and I'll see you on Thursday.
In terms of the exam, you said like when we're reading the chapters and stuff to just focus really on what you have on our slideshows.
Yes, and we'll review some of this stuff too next week on Thursday.